Hello, everyone. Thank you for attending today's webinar, 7 Best Practices to Optimize Staffing in Your Healthcare Organization. I'm Maureen McKinney, the Content Director here at Phreesia, and I'll be your moderator for this webinar. From value-based models of care to changing patient expectations, the healthcare system is evolving rapidly, and that means staffing strategies in your organizations need to transform too. The how in that equation, though, can be a challenge. We're very lucky today to have Deborah Walker Keegan with us to walk you through why staffing needs to change, as well as concrete practical optimization strategies. Deborah is a healthcare business consultant and well-known speaker and author, including of the forthcoming co-authored book, Staffing the Medical Practice, due out later in 2018. Deborah is president of Medical Practice Dimensions and a principal with Woodcock and Walker Consulting. She earned her PhD at the Peter F. Drucker Graduate School of Management, her MBA from UCLA, and she is a fellow of the American College of Medical Practice Executives. Before we turn the floor over to Deborah, I'd like to thank our partners Greenway Health and EMDs for their invaluable help in promoting today's webinar. And now, a few housekeeping items. Today's webinar is scheduled for 1 hour, including time for Q&A at the end of the session. At the bottom of your audience console, you'll see several application widgets. You can submit questions at any time using the Q&A widget, and I'll ask as many as time allows. In the resource list widget that looks like a green folder at the bottom of your screen, you'll find the slides from today's presentation, along with a Phreesia white paper and infographic about staffing. You can expand your slide area by clicking on the Maximize icon on the top right of the slide area, or by dragging the bottom right corner. And if you have any technical difficulty, please click on the Help widget. It has a question mark icon and covers common technical issues. Since it's always one of the most frequently asked questions, this session is being recorded and we'll share a copy of the recorded presentation by the end of the week. We'll be live tweeting highlights from today's webinar, so be sure to follow Phreesia on Twitter, @Phreesia. If your practice is active on social media, you can retweet our updates, and we encourage you to share your own posts about what you hear today using #PhreesiaWebinars. And now a quick word about Phreesia. Phreesia gives healthcare organizations a suite of applications to manage the patient intake process. Our innovative SaaS platform engages patients in their care and provides a modern, consistent experience while enabling our clients to maximize profitability, optimize their staffing, and enhance clinical care. To find out more about Phreesia, visit phreesia.com. And with that, I will turn it over to our speaker, Deborah Walker Keegan. Deborah?
Maureen, thank you so much. I am so excited to be here today and have the opportunity to share best practices in staffing. And it's really important today for us to think about staffing in a strategic way. Not only is our staffing overhead significant for many of our practices, some of you have 30% costs of staff in your medical practice as your overhead figure, but really, as we all understand medical practices and healthcare organizations, staff are not simply a cost. They are a valuable resource, and we cannot accomplish anything without a knowledgeable, productive, and engaged staff. It takes a care team and also a medical neighborhood and a community of healthcare workers and employees and talent to really achieve our value in today's healthcare equation. So we need to deploy staff to the correct work. We need to ensure staff are doing the right things and that they're doing them well. So today I'm going to talk about 7 different best practices to optimize staffing in your medical practice. Some of these will be new to you. Others might be a different angle that maybe allows you to think about staffing in a more strategic way. The first best practice will be staffing for the work, and this is a concept and a strategy to link your staff to the work, not just staff for the day or staff for the physician or staff for the half-day clinic session. Our second best practice will be to talk about how do you create a flexible staffing model. We know there's work variation throughout the day, throughout the week. We know Monday afternoons the phones are going to ring off the hook, and we know we need to be more flexible in order to link the staff to the work that needs to be performed. We'll also talk about redesigning the work. If we can leverage technology and redesign some work, we can change our staffing deployment models, bring them up to date, bring them current in today's world. We'll talk about consolidating work. Work consolidation strategies permit you to take advantage of economies of scale and scope, and they're certainly important today in a number of key areas in a healthcare organization. We'll also talk about delegating work to the top of licensure for your clinical care team, the importance of making sure that your clinical care team is highly engaged and doing the work that they are licensed to perform. And we'll talk about predictive and multi-site analyses to make sure you have staffing equity throughout your organization, and also to analyze staffing opportunity throughout your organization. And finally, our seventh best practices, the new frontier of healthcare. How are we going to staff in a value-based world? So that is our agenda for the next hour or so. Now, what we know from the MGMA data, and the MGMA, the Medical Group Management Association, has a lot of staffing data in their cost survey and their data dive instruments. And I've been fortunate to work with folks there to analyze that staffing data. And what we've learned is that the better performing practices employ more staff. They have a higher cost of staff on a per FTE physician basis. Now, that's because, of course, they have more staff. Also, they may have a different mix of staff. They may have a higher wage rate. But we know that they have a higher cost of staff on a per FTE physician basis. But the insight for number 3, really, really important. Their staffing cost as a percent of total medical revenue, so that is staff overhead, their overhead is actually lower than other practices. So they have deployed staff to the right activities that increase profitability in the practice. They're not just adding more staff, they are ensuring that the staff are deployed to the right work to contribute to the bottom line. So really important for us to think about staff strategically, as I said, and make sure that we have analyzed the impact of our staff on our own profitability. So this very first best practice is to staff for the work, not the physician, not the day, not the session, the traditional model on the left side of the screen, but to really think about the unit of work that you're trying to staff for. And to do this, we need to determine the unit of work that's been assigned to the staff. We need to measure the quantity of work that's been assigned to the staff, and we're going to apply some staff workload productivity data in order to calculate the number of staff we really need to perform this particular cohort of work. So why not staff per physician or per provider? Providers have different levels of productivity. We know that. We also know that there's different work involved in the different providers as well. So if we continue with a one-to-one assignment, for instance, of a medical assistant to each physician, we could have one medical assistant working really hard throughout the day as they're rooming and readying 30 patients, and another one, wow, gee, wonderful, they get to room only 18. And so we really want to ensure equity in terms of the workload. We want to be sure that we have, in fact, assigned staff the proper amount of work to perform. So this is what the staffing for the work is all about in terms of a concept. Now let's think about the unit of work. For clinical support staff, it typically is the encounter volume and the type of encounter. So I can staff differently for surgical practice than I'm going to staff for a primary care practice. But I am going to look at visit volume because that's important, and the visit type. For front office staff, typically to check in a patient, we're looking at arrived visit volume. We're not looking at scheduled visits because we know there's going to be no-shows, there's going to be cancellations. We want arrived visit volume, and often we need to predict what that arrived visit volume is in order to staff for the work. For our communication staff, those that are on the telephones and managing secure messaging, it typically is the volume of inbound telephone calls, the volume of secure messages. That's their unit of work. So what is that quantity of work that we've asked the staff to perform? And for billing staff, it's often a claim. So whether the claim is for $10,000 or whether it's for $100, you still have to go through all of the back-end billing processes to make sure that claim is submitted, make sure it's adjudicated, make sure that we've paid it, made sure we've followed on the claim. So often it is the claim. Now, I'd like to share 2 examples of this concept of staffing for the work. This is a graph of inbound telephone calls for a sample practice. And so you can see throughout the day, we have the top line, the blue line, that is showing the inbound telephone calls that are coming into this practice based on time of day. And then we have the pink line at the bottom showing the repeat calls that come in through the day. And if this were your practice, you already know some things. You already know that probably your phones are closed for lunch because look at that. There's hardly any calls coming in. You also learn, in terms of staffing, that we have not staffed probably the clinical calls very well because we have this huge bolus of calls coming in again as repeat calls throughout the day. People have not gotten their responses to the questions that they've posed earlier in the day. And so really, if that is our staff, our inbound telephone volume, and if we have a consistent or what we call a static staffing model, which is the same number of staff assigned to the phones throughout the day, we're going to be under or overstaffed throughout the day because you can see that we have high fluctuations, like at 10 o'clock, which is typical, and at 1 o'clock after we've opened the phones again for the lunch hour. So we don't want to just staff in a consistent, flat fashion. We'd want to be sure that we can identify the staff that we need based on the probable fluctuations in the inbound call volume for this particular practice. And if we do staff in a consistent fashion, I guarantee you that I can predict your call abandonment rate at certain times. Your time on hold at certain times is going to be much longer than at others. Average speed to answer metrics, all of those performance indices for telephone and appropriate call patient access management, simply due to a static staffing model. And so we really want to think about staffing for the work, and I said I would share with you how to do that. The first is to identify workload ranges that your staff are asked to perform. And Elizabeth and I have spent a lot of time sitting with staff in a medical practice, observing their workflow, and we've identified some ranges. But if you don't have access to our ranges, that's fine. Sit with your staff and identify about how long does it take to handle patient scheduling and admitting reg on the phone. About how long does it take for your staff to manage telephones with messaging. And then assume a 7-hour productive day. We do that conservatively because we know things happen in a medical practice. And you can identify about the range of time that it takes your staff in order to perform those particular functions. And of course, on this slide, I'm just showing a couple of the workload indicators. Patient scheduling with a full reg might be how your practice handles it rather than this mini reg. Telephones with routing might be what you have your operators doing, not just taking electronic messages and passing those forward. So there's many different workload ranges, but for this particular example, we're going to see what the midpoint is for this practice, and it's going to be 100 for patient scheduling with a mini reg and 400 for telephones with messaging. What do I mean by that? One staff member fully engaged in managing the inbound telephone calls should be able to handle 100 a day in terms of patient scheduling with mini reg and 400 a day if they were doing telephones with messaging. So that's what that means. So 100 for scheduling, 400 for messaging. And then we apply that expectation to the actual inbound call volume in order to calculate how many staff you need. So in this particular sample medical practice, here are our scheduling calls Monday through Friday, 250 on Monday, 50 on Friday. We know the expectation is that the one staff member can handle 100 calls a day. So how many FTE do I need to handle the scheduling calls? So we took 250, divided it by 100, and we got 2.50 FTE on a Monday. Look at Friday. Only need 0.50, only need half a staff member to handle that kind of inbound calls. We do the same mathematical calculation for message calls, only this time the expectation is that they can handle 400 in a day. Well, we need then 1.25 staff to manage those types of calls on a Monday, and on a Friday we need 0.25 to manage those calls. Now we can get much more refined in the data by looking not only at day of week but time of day. But this is how we staff for the work, recognizing that we don't need a flat staffing static model throughout the work week. We need to fluctuate our staff appropriately in order to staff for the work. Now I'm going to give you one more example of this concept because we think it's really, really important to be flexible in our staffing models. And this is for the front office. And let's say this is our sample practice. For their check-in for arrived visits, they have 150 patients on a Monday, 75 on a Friday, and checkout encounters not the same as those that arrived because some patients can slip out and don't need to have a return appointment, for instance, or may not need to be scheduled further in the system, and so they're sent on their way from the exam room as they're discharged from the exam room. And we have the same type of data, these workload ranges. And again, you can come up with your own. How long does it take your staff to manage check-in with registration verification only? How long does it take if they were doing check-in with full registration? It's obviously going to take longer. They're going to have a less volume that they can accomplish. And then checkout with scheduling and cashiering in our sample practice. Again, 70 to 90 per day. The midpoint is 80. Now for this particular practice, we're going to observe what their particular work processes are. And in this practice, we've decided that they really can manage the minimum there. That's all they can accomplish. So we're going to pick 100 for check-in with registration verification only. We're going to pick 70 for checkout, scheduling, and cashiering. And again, we're going to do this math. And we see that over the work week, we're going to need variable staffing levels. We do not want to staff in a consistent, flat way. Now, intuitively, folks kind of understand this. In a primary care practice, you know Monday afternoon is really, really heavy for phones. It's also heavy for inbound patients, right, face-to-face visits, because we have pent-up demand from the weekend. So intuitively we know it. But at the same time, what we really need to do is make sure we've deployed the staff appropriately to manage this quantity of work. Now, recognizing that I've just said, wow, we need, on this particular example, we need about 3 staff, 3.25 staff on a Monday. We only need 1.61, 1.1.5, 1.6 on a Friday. Oh, Deborah, what am I going to do? Do I just send people home? What do I do? No. What we want to do is this second best practice, and that is to create a flexible staffing model. So we know we don't need the same number of staff each day of the week. If we can predict that Monday afternoon is where it's heaviest on our phones, where we have a work surge, for instance, we can assign part-time, per diem, contract employees to that Monday afternoon. That's one of our flexible opportunities. That also saves overhead costs because typically for per diem employees, you're not paying benefit costs, for instance, and you do not have a bolus of staff sitting around through the week without a full complement of work. And so for work surges, for coverage opportunities, we can actually predict our planned and unplanned absenteeism. You just take a look at your historical trends in that area, and you know when you need coverage. You know when you're going to probably have work surges. So we can actually identify part-time, per diem, or contract employees and staff to help us at those particular challenging times throughout the week. We can also adopt some work rotation strategies, which is cross-training of staff to allow them to easily move in and out throughout the practice in various work functions. So we can train a medical assistant to be on the phones. We can train a telephone operator to manage the front office. We have an opportunity to really extend our staff during the peak periods. We know, for instance, that our checkout staff are not going to have anything to do probably for the first 30 minutes in the morning. Well, maybe they could be on the phones managing the phones while we're seeing those first patients and then getting them ready to be checked out if we still have that traditional checkout approach. Some medical practices have also decided to create a real flexible staffing model by having super trained medical assistants. By super trained, I mean that they're trained in front office and medical assisting. Some of them are also trained in imaging. But it really allows you to move and deploy the staff based on variable workload that occurs throughout the week and throughout the day by having super trained MAs at work in a medical practice. And then also, let's not forget that healthcare as an industry has been really slow in managing teleworkers and actually setting up folks working from home, really working from any place they have the technology to do so. And with teleworkers, you can also have part-time opportunity where they log on to manage call center calls, where they manage triage and advice at various times throughout the day. Coding, population health management, they all lend themselves well to teleworking. And so really thinking about newer models of staffing rather than the traditional, let's staff with the same number of folks throughout the week, and also really thinking about whether it is an opportune time now to supplement a core staffing team in your organization with these other models. And again, we would want to be predicting this variable demand in terms of the units of work. We know that we can predict much of that, and it allows us to then really staff consistent with the work and the work needs of a medical practice. You know, if Bob and Sally both call in sick today, really the show still has to go on, and it should be ideally seamless for the patient and the patient's perception of service that your practice provides. So really important to think about these newer models, and there's plenty of material out there for you to be reading about, talking to your colleagues about, and seeing what they're doing in order to create this flexibility that we really haven't had in the past to the great extent. Our third best practice is to really leverage technology and redesign the work. And this is a strategy I think really, really important. Once you redesign the work, having the right staff doing the right things, you are going to then alter your staffing deployment model. So here are just a couple of examples of that. In terms of managing non-clinical calls, there's a lot of ways to do that. One is to have your front office staff do that, with all the staff taking the calls as they ring throughout the day. Another is to have just your checkout staff manage the calls, while your check-in staff is actually managing that front-end reception and verification of information and checking patients in. You could have a call center managing all calls, managing only scheduling calls, managing only referring physician calls. You could have a call center to manage those calls. You could also have a portal message with a patient request via secure messaging, information regarding their schedule, information regarding when they're due to have their next appointment, all sorts of questions, allowing them to cancel their appointment with you via the portal. And then finally, you can provide self-service. Well, that is a patient self-scheduling. It is a patient also going online and looking at their statements and providing bill pay, which is going to reduce the number of inbound calls for non-clinical kinds of activity. And so if we think about this, let's say that we then market and engage our patients in secure messaging for non-clinical calls and in self-service. We are going to need less staff devoted to the telephones because we're going to have less inbound telephone calls for those same purposes. So as we migrate to more technology, as our patients become engaged in that technology, it alters the number of staff we have that are deployed to specific work functions. So it's really important for us to think about technology, think about what our patients want. Typically, they want 24/7 access for clinical and non-clinical activities, and they are demanding that type of value in today's world. So time to think about redesigning the work of telephones, redesign for non-clinical calls, redesign the same for our clinical calls. Again, you could have a flow nurse that manages the calls. You could have a triage unit. You could have secure messaging in a big way where they can message their clinical questions throughout the day, or online self-serve where they can get their test results and the prescription renewals managed online. And if patient self-serve, you're going to have less of a call volume. Your staff can be meaningfully engaged with patients for those patients that really have to talk to the staff regarding their clinical conditions, not simply using clinical support staff to impart information. What is my test result? If patients can get that via self-serve with a note from the physician in terms of those results and what next steps are planned, then you do not need that synchronous telephone call between a clinical staff member and the patient. And so we're going to leverage technology and then change our deployment model. For redesign of work in the front office, for check-in, I'm seeing a lot of self-pre-registration via the portal. I'm seeing a lot of self-check-in via kiosks or tablets, and also exam room check-in with mobile tablets, so that we are, in fact, in many practices, bypassing the check-in desk altogether. And as soon as the patient arrives, we're rooming them in the exam room and managing all of those check-in functions within the exam room itself. No reason we can't do that. We have the technology to do it. Same with procedure scheduling. That can be done in the exam room. It can be done after the patient visit. It can be done via the portal electronically with that patient, involving that patient in terms of that schedule, rather than the patient leaving the exam room, going to a scheduling area, standing in a queue, and waiting to be scheduled. So as you think about redesigning the work, whether it's your telephones, whether it's your front office, whether it's your back office, you have an opportunity to change the traditional work processes, have them become more advanced, more technology sophisticated, and allowing you to redesign your staffing model. And these staffing redesigns are really becoming the norm today. Many of our traditional practices really are recognizing that they have been doing things the same way over and over again, and that they have not leveraged technology and the newer technologies that patients want to engage in with that work. So really something to think about in terms of a best practice for staffing. We can change our entire staffing deployment model as we leverage technology and move forward in new ways and a new direction. Our fourth best practice is work consolidation, and that does mean centralization to some of you, but really it's consolidating the work to provide enhanced staff knowledge, to improve patient access, to take advantage of economies of scale and scope, and to provide a consistent patient experience for your patients. And the type of work that is available for work consolidation are the call centers, nurse triage, referral management, case management, population health. Anytime you can really focus the work with an engaged unit that really has the opportunity to become expert at what they do. And it allows you to stratify the work and deploy the appropriate staffing to the work to be efficient and effective. And you know, if you don't consolidate some of the work, what you're going to see over time is some work is going to fall through the cracks. So for instance, if you continue to have a one-to-one relationship between the physician and his or her nurse or MA, and that person is expected to room 20 patients a day and take 90 phone calls a day, I already know that those phone calls are going to be delayed. We're going to have those repeat callers like we saw on an earlier slide throughout the day because a single individual can no longer manage that work quantity that they've done in the past. All of the work is much more cumbersome. We have medical authorizations. We have check boxes for clinical protocols. We have risk contracts where we have to ask and engage patients in certain indices. We have a lot more complexity in the work, and so that allows us to think about how to accomplish the work in the most appropriate way. Our fifth best practice is to really delegate to the top of licensure for your clinical support staff. And this is really, really important because clinical support staff are, in fact, highly valuable in a medical practice. I know they're valuable members of the care team. But really, what is your mix of MAs, LPNs, and RAs, and what work have you been delegating to them? I go into medical practices to conduct practice operations assessments, and it's very sad when I see a licensed nurse just rooming patients. It makes no sense to me. And when I ask why you have a licensed nurse doing that, the answer is often, well, just in case they get a phone call of a clinical nature and the physician's not available to assist, we know a licensed nurse can manage triage. Well, how many phone calls do you get? Because if you get a cohort of those kinds of calls, then I'm going to suggest having focused nurse triage advice unit rather than every single doctor having their own nurse just for that opportunity to handle a single phone call that may come in throughout the day requiring triage. Now remember that the scope of work varies by state in terms of what an RN can do, what an LPN, what an MA can do in your particular practice. So not only does it vary by state, but it also varies based on your providers and what they're willing to delegate to your staff. So that could be why you see that another practice that you talk to and network with in another state really has a whole different staffing deployment model because they're able to deploy these staff in different ways, again, related to the state requirements and regulations. But here are just some examples of what some folks are doing in terms of a medical assistant. They're doing pre-visit planning, disease registry entry, and medication reconciliation. Notice I don't have just retrieval and rooming there. The LPN, nurse visits within their scope, educating and coaching, managing care transitions. An RN, treating complex illness, triaging patients, and managing population management. And so what I want to do is kind of give you an exercise to think about as you look at your clinical skill mix. And this exercise is real easy. It's real fun, too. And it involves sticky notes, which are often fun to do. And what I would recommend that you do is take a sticky note and write on it every different activity you have your clinical staff doing. So, for instance, in this example, you see prepare for the visit, retrieve the patient, take vital signs, review the medications, etc. So a sticky note for each separate task you have your clinical staff performing. Then on a wall in your office, put a column of MA, LPN, and RN, and based on your state regulations and based on your physician delegation authority, put those sticky notes under the correct column. And as you see, in some cases, the sticky note really can be totally outside of your clinical support staff. Processing referrals doesn't involve an MA, an LPN, or an RN all the time. But where does that sticky note go for your particular practice, your particular state, your particular needs? And it'll allow you to see, I think, in many cases as I do this exercise with practices, that we may be not using our licensed staff to the level that we expect. And so it may be really appropriate to think about deploying the staff in a different way. So for instance, a team nurse could support 3 to 6 physicians rather than each physician having a licensed professional. Or clinical calls could be managed by a consolidated nurse triage advice unit rather than having each nurse responsible for that in addition to rooming, for instance. So real opportunity for you in this particular example to have an exercise where you can evaluate your clinical skill mix. Now, those of you in larger healthcare organizations with multiple sites, I would encourage you to also conduct this multi-site analysis with your clinical skill mix. And this is site ABC in our example medical practice or healthcare organization. And this is staff FTE per FTE provider. And as you can see in site A, they've got 1.00 FTE staff MA, no LPNs, and 0.30 RN for a total of 1.30 clinical support staff per FTE provider. Site B, similarly, we see the MA, the LPN, the RN, and they have a total of 1.50 staff FTE per FTE provider. Site C, they have a total of 2.00 staff FTE per FTE provider, and then you can apply a benchmark, an external benchmark. Let's ignore the benchmark for a minute, ignore that far right column, and let's look at sites A, B, and C. We can conduct internal benchmarking in an institution. Let's say these sites are the same specialty. Let's say that these sites have the same general levels of productivity in terms of the visit volume. Wow, we have now a variation between 1.30 to 2.00 staff FTE per FTE provider. And the real question is why? Now let's just look at the RN line. The RNs, we have a 0.30 in site A, but we have a 1-to-1 relationship between the provider and the RN in site C. And the real question then is why? And so you can conduct internal benchmarking just among your sites, but you can also apply an external benchmark. And this is just an example external benchmark. You're going to need to pick the right benchmark specific to your specialty, your practice ownership, your practice size, for instance. But with an external benchmark, it allows us to also further question, why is it that we're so different? And as you can see there, the benchmark median of 1.50 total staff, wow, you could initially say, gee, site B, right on, no problem. But take a look at that clinical staff skill mix. The skill mix is vastly different between site B and the benchmark median. And so a real opportunity for you to conduct multi-site analysis, internal and external benchmarking, to determine if you have areas of opportunity. And what you want to do, of course, is realign staffing across the enterprise so it has equity. And especially if these are the same specialties, you can definitely see that over time, the staffing model has morphed or changed, or a certain provider wanted an extra nurse, or all sorts of things happen over time. And maybe it's now time to realign your staffing in a more consistent approach throughout your enterprise. Now, our sixth best practice is to really conduct predictive analysis. And this is fun because it ensures equitable staffing across the organization. And so our question here, are staff performing at consistent productivity levels throughout the organization? Well, let's look at this for a minute. Let's say we have 3 receptionists working every day throughout the week, Monday through Friday. There's 3 receptionists. Which days are they working harder, and which days do they kind of have it easy? Well, if we apply staff FTE per encounter, we can really see that the really easy day, of course, is Friday, and the toughest day for everybody is on Tuesday. And so, again, we're back to this, why are we staffing at a consistent fashion? We really want to staff for the work. We want the staff working at a common productivity level throughout the week. We don't want this downtime on Friday, and we don't want staff running around like chickens with their heads cut off on Tuesday. We really need to create an atmosphere for patients, for providers, that permits us to be effective and efficient throughout the workday as well. And so what we can do is then do predictive analysis and create a new staffing model in this particular case. So in this example, let's assume that 0.030 staff FTE per encounter is a target that we determine is appropriate for this practice. Well, if that's the case, we can actually calculate the number of staff that we need based on encounter. And this is predictive analysis. And it's kind of fun to do, and you can see that if you continued your static staffing model, you're going to need more staff on Tuesday and a whole lot less staff on Wednesday, Thursday, and Friday. And so work to be equitable throughout the week really allows us to use predictive analysis in order to make that happen. And practices will often then have a core staff working at the practice throughout a work week and using a flexible model to add or deduct staff as we discussed earlier. So using predictive analysis to figure out, gee, what kind of workload are we talking about? Is it consistent throughout the week? And is there a better way that we can create more equity in terms of the actual work that is being tasked to perform? Lastly, our best practice, of course, is this strategy to start thinking about how to change your staffing model for value-based care. And obviously, value-based care is the new frontier. It's individual personalized care, 24/7 access to care and information. Patients are supposed to be engaged and become partners in their health. We have a high-performing care team. And if you think about it, it involves reaching out to patients we're not seeing. Beyond the patient-facing visit, it's reaching out to patients you're not seeing, using a registry to monitor and maintain health, identifying high-risk conditions and reaching out to those patients, managing chronic disease over time, not just through episodic visits. And in terms of value added, if you think about it, the only portion of the visit from the perspective of your patient that is value added is the diagnosis and treatment plan. All of those other steps of calling and getting an appointment, checking in and queuing in line, waiting to be called back, even stopping in the hallway to be weighed and have our vitals checked, all of that extra steps that we put in beyond the actual diagnosis and treatment plan and what we need in order to achieve that is really not value added for a patient. And so let's think about what would value-based care look like. And I just want to share with you a kind of a new model. So the patient submits a secure message to her care team to describe a health issue. The physician orders a test the same day, and the patient is notified of the order and instructions via the portal. The patient's given a mobile health device that transmits the test data to the ordering physician via secure electronic means. The results of the test are securely electronically transmitted to the patient with next step recommendations. In this example, for instance, the patient's care team notifies the patient an ultrasound is recommended, with the patient able to ask pertinent questions via the portal. The care team member sends the order to the imaging center. The imaging center sends a secure electronic link to the patient to self-schedule her appointment with instructions she should be seen in the next 48 hours. Wow, velocity to care. The patient travels to the imaging center for her ultrasound, and the results of the ultrasound are transmitted to the ordering physician and the patient the same day via secure electronic communication, with the patient offered a video visit to discuss the findings and next steps with the physician. Wow. That's what we're talking about for value-based care, and I know we're not all there yet, but it does involve new roles. And typically, in a patient-centered care team, we will have higher clinical support staff than in other practices. And in fact, in patient-centered medical homes, there's often 15 to 20% more clinical support staff than other practices that are not a patient-centered medical home. And that is due to the new roles, where you are reaching out to patients. You're not just focused on an episodic patient-facing visit. So there's care managers or panel managers reaching out to patients, transition managers as we transition from inpatient to outpatient, inpatient to home, outpatient to inpatient, inpatient to skilled nursing facilities. There's nurse navigators that help patients identify where they need to go along their journey, share with them an itinerary for their course of care. There's health and wellness coaches, clinical pharmacists, behavioral health specialists, data analysts. There's a lot of new roles. And so it's time to think about where your particular organization wants to start in terms of, or continue in terms of its staffing for value-based care. And so the first step is really identify the work that needs to be performed. And some of you have that work needing to be performed now. And I think of value-based care in terms of access, coordination, and population health. And so as you see on this slide, under access, we have the navigation, secure messaging, telemedicine, mobile health. Under coordination, we have transitions, care management, coaching, self-directed care. Population health is our outreach, patient engagement, panel management, data analytics. Where do you want to start for your particular practice? Now, different practices, different healthcare organizations are on a different timeline and a different learning curve when it comes to staffing for value-based care. Often this is market-driven. Often it is contract-driven. If you take on a full risk contract tomorrow, you're going to be staffing differently in order to ensure that you meet all of the indices you need to for a patient population that you're now managing and assuming all the risk for. So is it time now to start expanding what you currently have or developing more fully what you currently have been thinking about? So secure messaging. Have we in fact engaged our patients to the level that we expected? What more can we do there? Is it time to have some video visits in between scheduled patient-facing visits to assist patients to maintain their health and wellness? Where do you want to start on your particular learning curve? Really important to think about. We can also use predictive modeling here. Many practices are getting very sophisticated in this regard. And this particular example, you're seeing care outreach. And for our highest risk patients, they may get 1 call a day. For our moderate risk patients, they may get 1 call a week. And for our low risk patients, we may reach out to them 1 call per month. But we're going to use standard care management follow-up protocols and predictive modeling to assign a risk level to the patient, which helps us to really deploy the staff in a material way for value-based care. In this particular slide, you see an example of a care team used to provide value well beyond a patient-facing visit. Now, this is just 1 half-day session. There's 85 encounters that the physicians, the nurse practitioners, the nurse, the triage staff, the secure messaging staff, the case managers, the navigators, and the home health visit nurses are having with patients in a single half-day session. And on this particular slide, there's only 1/3 of the patients being seen in the traditional face-to-face visit with a provider. All the rest, in terms of triaging, secure messaging, care management, navigation, are really tremendous benefits to patients in terms of ensuring that patients maintain their health and wellness, that they have active engagement with a value-based care team. So that's where we're headed, and I would encourage you not to tackle the universe overnight, but to really identify what your patients' needs are, what your practice needs are, and where you can begin the learning curve or extend your learning curve in terms of creating a value-based care team fully deployed to creating value for your patients. So we talked about 7 different best practices to optimize staffing in your medical practice and your healthcare organization. The first was staff for the work, making sure we're linking the staff to the work that needs to be performed, using flexible staffing models, recognizing that wide variation in work throughout the day, throughout the week, throughout a single day in terms of hour per day. Redesigning the work in terms of leveraging technology, and that allows us to then redeploy our staff to different activities rather than providing just information to patients. We can redeploy the staff differently. We talked about work consolidation, delegating to the top of licensure, some examples of predictive and multi-site analyses to help you identify staffing opportunity in your practice, and finally, to start thinking about how we're going to change our staffing models to ensure value-based care. So I want to thank you very, very much for attending the webinar, and Maureen, I'll turn it over to you for the Q&A. Thank you.
Thanks for a great presentation, Deborah. And now, as you said, we can begin the Q&A portion. A reminder to all of you listening, you can submit questions at any time using the Q&A widget that's at the bottom of your console. So Deborah, we've had several audience questions come in, so I will dive right in. How do staffing levels affect practice profitability?
It's a really good question. I think one of the early slides I pointed out that if we can in fact deploy the staff in an appropriate way, they can in fact enhance profitability of a practice. And so many of the folks on the line are still in a fee-for-service environment, and profitability depends on the ability to streamline patient flow, have high patient visit volumes, and staff are really a resource, not a cost of doing business. And so if we can identify the right work for the staff so that they are deployed to support practice efficiency and productivity, then we will in fact also assume that profitability because the staff are deployed to the right work in order to support high visit volumes, if you will. Now remember that data suggests that better performing medical practices have higher physician productivity, and they actually have more staff. However, the cost of staff as a percent of total medical revenue is lower. So again, it's that right staff doing the right things to support physicians in the practice and therefore support the bottom line.
Here's another question that just came in. How do I find out what the scope of work for clinical staff is in my state, and is it something that changes often?
That's a good question. When I go into a medical practice, I'm always having to research it, and I don't know that there is a consistent place to go by state, but I would just frankly Google it and say, medical assistant scope of practice in the state of Maine, right? And it'll probably come up. And so you can also look at some nursing organizations. They usually have that pretty predominant as well. But it's a really good question. I don't have one where I always go to it. I'm constantly searching. So maybe there is a place, but I haven't found it yet that's consistent state to state. But you can start Googling it and you'll start to see the regulations come up.
That's helpful. The go-to answer, Googling, right?
Sorry.
And no, I think it's I think it's great advice. So you mentioned a super trained MA. This question is asking a little bit more detail about that and what that training would entail.
Sure. And so with super trained MA, you typically are actually having a certified medical assistant because that training is consistent, and you train them in their front office work. And so how to manage phone calls, how to manage registration processes, how to manage your check-in and check-out functions as well. And typically to do that, you're developing your own internal training tools to make sure that these staff have been trained appropriately, but you're doing that all the time anyway, right? Rarely are you hiring someone that knows exactly how to manage your front desk when you have a vacancy. Rarely are you able to hire them within their 2-week notification period, so you're going on for a long period of time without having a replacement staff member. So typically what we're doing is recognizing here is a certified medical assistant. We're going to provide internal training to train them to front office work so that they can seamlessly do both jobs. Typically also you're going to provide a bump up in terms of the wage rate because you recognize that these are really valuable employees that now have different skill sets, right? They have a broader skill set in terms of allowing you to deploy them where they're needed. It clearly helps when you've got coverage issues and you do not have the appropriate type of staff in your practice. You don't have to say, oh, I need a front office staff member. I can use anyone in my back office who's also trained in front office in order to move them backwards and forward or backwards wherever you need them in terms of the front office and back office. So that's typically how it's done. Obviously, we want to be sure that the staff maintain their level of proficiency in both types of activities, whether it's back office or front office. And so some folks will make sure that we have appropriate rotation strategies so that we are engaging medical assistant Sally in that front office so she doesn't lose those skills, for instance. So important to balance where you have them assigned, where you can do that. But that's I think the easiest way to approach it that I've seen is already have the certified medical assistant and train them to front office work.
Thank you. I'm sure this is a question that many people who are listening can relate to. Given the content of your presentation, how can practices convince physicians that there is a need for more staff and the benefit of that?
And that's a real important question because, you know, sometimes physicians can see the cost of staff, but they don't see them as the resource. And that's why I think that first slide that I shared that showed that better performing practices. Now these MGMA better performing practices are better performers because they're financially better performers. That's the only measure MGMA can look at. They don't have the quality of care or the patient satisfaction, for instance. And so typically I am sharing that data with physicians so they can see that if we would add one more staff, for instance, and we deploy the staff in this way, this is how many additional visits or additional types of services that we can provide. And so I typically will do a return on investment analysis to show them the cost of the new staff member and where we think we can make a difference in terms of the additional volume or the different type of service being performed. I use data. I think the data the physicians can grasp, the data the physicians are engaged in, and if they can see a good return on investment, then they typically will be very supportive of a change to the staffing model. So it's looking at staff as a resource and a contributor to the practice, not just simply as a cost. And part of that is education, educating them to what better performers look like, educating them to understand the impact a staff member can have on the bottom line. And so the data is really, really helpful in that regard.
Great. You mentioned a lot of the different tasks of value-based care and things like care coordination and patient outreach. And obviously, as you said, there's probably more clinical, there's a need for more clinical support staff. Can non-clinical staff play a support role in those tasks? Can they help out with things like care coordination or patient outreach or navigation or things like that? Is there a role for them to play there?
Definitely a role for them to play. And, you know, who's going to set up the telemedicine or the video visits, right? Non-clinical support staff can actually set those up. Who's going to capture data to see that we had what was our emergency room visits on our patient population? Clinical support or non-clinical support staff can clearly have a valuable role there. Our data analytics, really, really important. You're looking at I think the latest statistics I saw was diabetes visits are now 25% of emergency room visits, and I'm like, whoa, that's absolutely huge. What is our diabetic visits in terms of emergency room utilization? Learning that data, understanding that data, and then engaging with our patients to change where they access care, how they access care, really, really important. So I think there's a lot of roles there. And again, following that same exercise, do you need a clinical licensed staff member doing this, or can a non-clinical staff member manage it? Typically, when you're reaching out to patients and reminding them that they need to have their diabetic foot exam, for instance, those types of calls can be managed by non-clinical staff at the same time, or secure messaging, frankly, with the patient. But at the same time, when you anticipate follow-up clinical questions, so typically when we have the higher risk patient or the very complex chronic care patient or someone with multiple chronic care conditions, typically those patients are where we want to make sure they're interacting with the right clinical staff that can manage these very difficult follow-up questions. But there's plenty of roles for non-clinical staff to engage in.
Deborah, we just had a question come in that I think is an interesting one. It's very practical. It's, you know, given the time constraints that practice managers face, do you have recommendations on how practically they can take a step back to gather these statistics and think strategically about what to do and implement those changes given how much they're trying to do in a day?
Sure. You do not need to tackle your entire staffing model overnight. Just pick one area that you know probably needs some help. I mean, you have complaints from patients, you have complaints from staff, you have a turnover rate in a particular area, an area where you know that there's technology opportunity and you haven't tackled that technology. I would just pick one area that to initially focus on. Let's say it's the front office, and let's say you haven't adopted technology. And I would then start reaching out to my network of folks. I would reach out to the vendors that I contract with and ask them different ways to conduct the work. I'd reach out to some reading and some other articles that are available, obviously. And you have an opportunity then to say, okay, this is what I'm going to study right now. I'm going to see what's going on in terms of best practices in this particular area, and then I'm going to develop my own plan at a timeline that makes sense for me. And that may be that you tackle one particular area or one particular work task within a quarter or within 6 months, depending upon what your particular impacts opportunity of staffing that you have, as well as your own workload that you're trying to juggle, obviously, very busy throughout the day. But still, if you say you're going to do that and you tackle that, it's one step further, right? It may be slower than you want to do, but you are making a trajectory. You are moving the organization forward in terms of improving the work and bringing it to more current work, as well as changing your staffing model accordingly. So if you don't ever do anything, then you're going to be stuck in a traditional model, and you're going to have this really, really steep learning curve when all of a sudden you get a risk-based contract, for instance, or you get a payer in your community that decides that they're going to start measuring, monitoring you on certain indices. So you need to start somewhere. But I would pick then your biggest bugaboo, what you know just doesn't feel right, what you've seen in other practices. Certainly many of you are patients in other practices. You've seen how they run, and you might have liked something that you saw. You could import that in your own practice, but you could start there. And then once you've tackled that, then it might be easier to then have a plan where you say, okay, every quarter I'm going to look at a different area of my practice, and we're going to start moving in the right direction. I think it's real important to not tackle too much, but to begin the process of beginning that learning curve and beginning the opportunity to transition your staffing model to something more current.
Great advice. That's all the questions we have time for today, unfortunately, but on behalf of Phreesia, I want to sincerely thank Deborah Walker Keegan for delivering an informative and engaging presentation, and thank you to all of our attendees for joining today's webinar. Have a wonderful rest of your day, everyone.